Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Rituximab Extended Schedule or Retreatment Trial for Low Tumor Burden Follicular Lymphoma, Eastern Cooperative Oncology Group Protocol E4402 by Brad S. Call and colleagues. My name is Jonathan Friedberg, and I am Director of the Wilmot Cancer Center at the University of Rochester, Rochester, New York, USA. My oncologic specialty is hematology, specifically hematological malignancies. Since its approval in 1997, the anti-CD20 monoclonal antibody Rituximab has had a profound impact on the treatment and outcome of patients with follicular lymphoma. Overall survival for this incurable disease has dramatically improved over the past 2 decades, and the routine incorporation of Rituximab into chemotherapy regimens has demonstrated significant trends toward improved overall survival compared with chemotherapy alone. Rituximab is now appropriately utilized ubiquitously in the treatment of follicular lymphoma, both as initial therapy and in the setting of relapse disease. It is therefore remarkable how little was known about the optimal schedule of single-agent therapy with this antibody in the setting of follicular lymphoma, as numerous strategies have been employed in clinical trials without direct comparison. Fortunately, 2 recently published manuscripts have largely closed this knowledge gap. First, Ardeshna and colleagues conducted a randomized trial of patients with low tumor burden, advanced stage follicular lymphoma, comparing 187 patients initially approached with observation to 192 patients treated with weekly ×4 Rituximab, followed by 12 infusions of Rituximab given at 2 monthly intervals for 2 years. There was, not surprisingly, a significant difference in the time to start of new treatment between the 2 arms, with a median follow-up of 46 months. 56% of patients in the watchful waiting group required new treatment, compared to 17% of patients in the maintenance Rituximab group. Importantly, though, only 4 patients in the observation group received Rituximab as subsequent management approach, and the remainder were treated with chemotherapy. There was no difference in 3-year overall survival, 94% for watchful waiting and 97% for the maintenance Rituximab group, and there was no significant difference in biopsy-proven histological transformation rates between the 2 arms. Patient-reported outcomes in this trial suggested improvement in psychological well-being in the Rituximab group, but otherwise there were no significant differences in symptom burden or physical functioning domains. Interestingly, the original design of this trial included a 3rd arm of single-agent Rituximab weekly ×4 alone, without maintenance, which was prematurely closed due to poor accrual. 84 patients were enrolled on this arm before closure, and the outcomes in this group were similar to the maintenance Rituximab arm, without statistically significant differences in time to start new treatment. These authors concluded, quote, Rituximab monotherapy should be considered as an immediate treatment option for patients with asymptomatic low tumor burden follicular lymphoma, close quote. In this issue of Journal of Clinical Oncology, Call and colleagues from the ECOG lymphoma group present results from the eagerly anticipated Rituximab extended schedule or retreatment RESORT trial, which was designed to evaluate the optimal use of Rituximab in this setting. 408 patients with low tumor burden follicular lymphoma by Guelph criteria, low-grade histology, advanced stage disease without bulk were enrolled. All patients were treated with rituximab weekly times 4, and 289 patients, or 71%, responded and were subsequently randomized to 2 different dosing strategies of rituximab. Retreatment rituximab patients were observed and were retreated with rituximab at progression. Patients in the maintenance rituximab group received a single dose of rituximab every 13 weeks until treatment failure, which is a slightly different schedule from the Ardeshna trial. Treatment failure was defined as no response to retreatment rituximab or progressive disease between scheduled rituximab doses in the maintenance rituximab group. With a median follow-up of 4.5 years, there was no difference in median time to treatment failure between the retreatment and maintenance strategies. And similar to the Ardeshna trial, overall survival was outstanding in both groups, 94% at 5 years. There was no difference in histologic transformation incidence. Overall, both strategies were well tolerated with infrequent severe adverse events. One patient in the maintenance group died of progressive multifocal leukoencephalopathy. The median number of rituximab doses administered in the retreatment group was 4, compared with 18 for the maintenance group. Preliminary analysis of patient-reported outcomes for health-related quality of life and anxiety revealed no differences between the maintenance rituximab and retreatment groups. The authors concluded that in the common scenario of low tumor burden follicular lymphoma, if single-agent rituximab is utilized, a strategy of retreatment at disease progression is preferable to continuous maintenance, given similar outcomes and substantial decrease in resource utilization. The Resort and Ardeshna manuscripts raise several important issues in the approach to low tumor burden follicular lymphoma. First, they both confirm outstanding 5-year overall survival for this subset of patients approached either with initial observation or various rituximab strategies, significantly better than previously reported series. Despite differences in progression-free survival noted in the Ardeshna trial, there is no evidence yet that an aggressive maintenance strategy impacts overall survival as compared to initial observation or first-line rituximab treatment without maintenance. Moreover, there were no patient-reported outcome improvements noted in the maintenance rituximab group in the Resort trial, calling into question whether improving progression-free survival of an indolently behaving asymptomatic follicular lymphoma, which responds to initial rituximab, will truly impact the natural history. Indeed, this suggests that progression-free survival may no longer be a true surrogate marker for clinical benefit in low tumor burden follicular lymphoma responding to rituximab. Avoidance of chemotherapy and associated toxicities has long been cited as another rationale for a maintenance rituximab strategy in follicular lymphoma. In an era where routine treatment for follicular lymphoma will soon include lenalidomide, ibrutinib, idelalisib, and other novel targeted agents with minimal toxicity, this argument no longer holds true, as many patients may never require chemotherapy. Finally, although severe toxicities with maintenance rituximab in both Resort and the Ardeshna trial were uncommon, myelosuppression and low-grade infections clearly contribute to possible morbidity in the setting of maintenance rituximab, particularly when rituximab is continuously administered every 2 or 3 months. Further follow-up of the Ardeshna trial is needed to definitively determine whether an early rituximab intervention will affect transformation or long-term survival compared with initial observation. But based upon findings to date, I think this is very unlikely to occur. Indeed, perhaps the most revealing aspect of the Ardeshna trial is how well the 84 patients enrolled on the brief rituximab arm fared. If single-agent rituximab were utilized at progression for these patients as a retreatment strategy, I suspect the outcome would have been exactly the same as the retreatment rituximab arm in RESORT. The implications of the RESORT findings on resource utilization are likely to be substantial. Even in the National Lymphocare study, which enrolled patients between 2004 and 2007, before many of these data sets were published, maintenance rituximab was frequently incorporated into the upfront treatment strategy. As the healthcare system in the United States rapidly evolves toward accountable care and population management, there is increased pressure to demonstrate clinical benefit for expensive oncologic interventions. In my opinion, maintenance rituximab in the low tumor burden patient with follicular lymphoma does not meet this bar. A key remaining question is whether the findings of RESORT can be extrapolated to the scenario of follicular lymphoma with high tumor burden, treated with rituximab and chemotherapy. The PRIMA study has demonstrated substantial progression-free survival benefit to a maintenance strategy compared with observation in this situation. Although interestingly, 6-year follow-up of this study, recently reported at the 2013 ASH meeting, still does not reveal any differences in overall survival or rates of transformation between the two groups. Different from the low tumor burden setting, 2-year progression-free survival does appear to be a robust surrogate for overall survival in these higher-risk patients. But most of the benefit observed with maintenance rituximab occurs after 2 years in the PRIMA trial. Therefore, I believe that were a RESORT-like retreatment strategy to be evaluated in the PRIMA high-risk patient population after chemoimmunotherapy induction, it is very likely that the observed progression-free survival of maintenance rituximab would be minimized. In conclusion, Call and colleagues should be congratulated for an important practice-changing study. Maintenance rituximab should no longer be given to newly diagnosed patients with low tumor burden follicular lymphoma responding to single-agent rituximab induction, as a retreatment rituximab strategy has equivalent outcomes. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.